We are calling up Dr. Anagha HEROOR. She is the President-elect of the Maharashtra Ophthalmological Society, and she has got a very nice talk. You people are really going to enjoy this session. It's regarding complementary light distribution profile, a comprehensive guide to achieve spectacle independence in cataract surgery. Dr. Anagha HEROOR. She's a multi-talented personality, and we have a very nice talk from her. Over to you, Anagha.
Very good afternoon to one and all. Thank you so much, sir, for the kind introduction. Please start the presentation. So I would be speaking to you on multifocal IOL. So all of us in our cataract practice are faced with the dilemma of choosing the best lens for our patient. Whenever we think of multifocal IOLs, we think of spectacle independence and how our patients are going to benefit from the decision that we make in order to give them spectacle independence. So for the last 27 years, I've been focusing on advanced technology cataract procedures, especially that on presbyopia management. And I think all of you would agree that the basic challenges in these patients are: one, patient selection; two, IOL selection; third is patient counseling, and precise biometry and surgery. So when you think of advising a patient for a multifocal IOL, what is most important is doing a perfect biometry on a virgin cornea before doing a dilatation or applanation so that you get the perfect readings. A good ocular surface assessment, including management of an MGD if it is present. A topography, especially in cases of astigmatism, so that you rule out any kind of irregular astigmatism. OCT macula to look at any macular degenerative changes. A pupillometry to look at the scotopic pupil size and angle alpha. So if the patient has an astigmatism, instead of thinking of what would be the threshold, what we usually do is just put in the K1, K2 on the online Barrett-Toric calculator, and then that decides for us whether the patient needs a low-powered toric or we go ahead with a non-toric. And in case the patient has astigmatism, you also discuss the other options of a toric multifocal or LRIs, and if there is a residual astigmatism, you can always do a laser correction as a secondary procedure. So we would like to today explain to you about Vivanex geometric trifocal IOL family. Now what it has is basically two lenses. One is the geometric and the second is the geometric plus. Now, mind you, these two lenses are identical in their intermediate ad as well as the near ad. I repeat, the intermediate ad for both is 1.75 and the near ad is plus 3.5 diopters for both these lenses. So then what's different? This is what is different. So it is basically the light distribution for intermediate distance and near, which differentiates both these lenses. So if you look at the geometric plus, it has a 39.8% distribution for distance, and look at the near distribution, it's almost as high as 40%. So 38.6%, whereas in the geometric, it focuses more on the distance, and that is why it is a 50% distribution of light for distance, 21% for near. And that is why when you combine the two, you have an excellent visual quality for distance with the geometric and an excellent visual quality for near with the geometric plus. So when you combine the geometric with the geometric plus, you get excellent distance, excellent near, and a very good intermediate. Now this was the NINO study, which had almost 10 investigational sites, and they distributed at 2-3 groups. The first group was geometric in both the eyes, second group was geometric plus in both eyes, and then you had a geometric in one eye with a geometric plus in the other eye. 84% of these eyes showed a spherical equivalent of within plus or minus 0.5 diopters. But what is most important is this curve. You look at these three curves, the one in the red is what is most important, which combines geometric in one eye and the geometric plus in the other eye. So you can see that for distance, you have the maximum visual quality, as well as for the near, it has the tallest peak. So when you combine both of these, you get the best balance of high quality vision from distance to close of near. That does not mean that you cannot use it as a geometric combination or a geometric plus combination. So if you use only geometric, you would definitely get excellent far vision for those who don't probably need near vision. So if you look at the subjective patient feedback, more than 90% never used glasses. I've been using this since almost 2023 with a lot of these being paired approaches. We've used more than 156 implants. And as with any other trifocal IOL, it's important to have a perfect capsulotomy and a perfect nucleotomy. This lens we have used always with the Vivinex platform. It's one of the best preloaded technologies with the textured haptics and the optic edge, and you can see how there are those central rings and the peripheral diffractive zone. These were the bilateral implants. Most of them were 6x6. Almost none of them needed glasses. The visual quality was excellent. Very few of them really complained about glare and halos, which is obviously a part of the diffractive technology. If you look at the visual performance at different distances...
Anagha, you have 1 minute with you.
Yeah. So almost 97 to 99% of them were satisfied. And if you look at spectacle independence, dysphotopsia, and patient happiness, this lens really excels in all of these three. So what you need to be is a matchmaker. Choose the functionally optimum IOL for your patient and combine their visual expectations with the lens that you are putting. And if your patient is unhappy, remember that these could be the various reasons why a patient could be unhappy, and you need to really address these situations. Counseling of these patients is important. Need to take a special consent and also explain to them about neuroadaptation, glare and halos. So we use this light meter, and you can see that 255 lux is what is the minimum light intensity required to read. This was a patient who actually was extremely happy, and she was able to read for distance, intermediate, as well as for near without glasses. So I would like to conclude by saying that we get excellent results, good visual outcomes, minimal dysphotopsia, and with the ease of implantation with the preloaded advantage, we have promising new technologies today that give us better visual outcomes and happy patients. Thank you so much for your kind attention.
Fantastic.
Thank you. Thank you. Just one question. If you had cataract only in one eye, patient had, which would you choose, the distance one first, the geometric one first?
So for the first eye, I would always prefer a geometric, because the patient would get very good distance vision. And I would see how the patient does with that eye for reading.
Yeah.
If he's comfortable, then you can always go ahead with the geometric plus in the other eye.
That is, if he has, supposing he has no cataract, then
So
what will you
then we would have to probably see whether we need to use a trifocal in that case. Because then he would compare the contrast sensitivity in both these eyes.
Yeah, because this is essential to implant bilateral implantation in these cases.
I would always prefer a bilateral implantation for all my patients. If there is no cataract in the other eye, probably I would go ahead with an enhanced monofocal in that eye.
Do we look for the dominant eye in such cases when sir said that one eye there is no cataract and the other eye you have a cataract? With the dominant eye, do you
It's
do
not
a
really
distance
necessary,
correction, or it's
especially
not
in
necessary?
these, not really necessary, but you can always go for geometric in the dominant eye and the geometric plus in the other eye.
Okay.
Thank you.
And for those patients who are really aged and for whom, distance vision really doesn't so much matter and the reading is more important, for them we have even put geometric plus in both eyes.
Yeah.
And that also works well.
That also.
Dr.
Because
Anagha,
even that.
Dr. Anagha, one question. You said neuroadaptation. So, what is the time period that you tell your patient that this much may be the time for neuroadaptation?
So it depends on their age.
For this combination.
Yes. For any trifocal also that holds true. If it's a young patient who is motivated, he will take a lesser time to neuroadapt. And if you are also doing the other eye, immediately. If there's a big gap between the two eyes, then they'll never neuroadapt. So if it's an old patient who is really very finicky, they take a little longer. So you just see how their behavior is, and then you can tell them from a few weeks to a few months. If you tell them that within a week ho jayega, and then if they don't, then it's more difficult. So it's always better to under-promise and over-deliver.
Thank you. Any questions from the audience?
Any questions from the audience? We can take one or two questions. Okay.
Thank you so much.
We have
I'll go one last
thanks
question.
Anagha for a wonderful presentation.
Thank you.
What's your threshold for putting a multifocal toric? Like, what's beyond what cylinder you like?
Exactly. I mentioned that in my talk. I don't have a threshold. No, even if it's a
Prakhyat roop
0.5
na?
or a 0.75 ATR, you just put it in the Barrett Toric online calculator. If it shows a T2, you put in a T2. I don't have a threshold, and I think probably that's the way to go. Otherwise, you would probably have more of residual astigmatism, which in a case of multifocal IOL would give them unhappy patient.
Tell me, why do you prefer, you don't use a Toric calculator for these lenses?
So you can use that also, sir.
Because they almost have seen that
Yes, yes,
they are
absolutely.
absolutely almost similar. So you
Yeah.
can
No,
use
this I was just mentioning for any kind of
any,
IOL.
okay.
Thank you.